Our next talk will be by Dr. Anupam Raj. He is our newly appointed local consultant gastroenterologist, and he's previously done an MD on celiac disease and dietary therapy in IBS. So his next talk will be about clinical grey cases in celiac diseases.
So thanks for the kind introduction, and thanks for the invite to come and talk here today. So the purpose of this kind of next 15 minutes is just to go through two kind of hypothetical scenarios and just talk about some common things that you might actually encounter in primary care and the challenges associated with that. So for our first case, we have a 25-year-old lady who presents to primary care complaining of lethargy and bloating. So as a result of that, we do some blood tests. So this patient has normal full blood count, normal U&Es and liver function tests. And in view of the lethargy and bloating, we send off some celiac serology. And as we know, first-line testing, as per NICE guidelines, would be tissue transglutaminase antibodies. So in the meantime, I think Charlie's already touched upon this, but as a reminder, how common is celiac disease? Now, I know it's going to be quite difficult to have interaction online, but in the audience, by show of hands, who thinks it's 0.01%? No, nobody? 0.1%? 1%? So it looks as though that's almost everybody in this room, and 10%, presumably nobody else thinks that. So that's absolutely right. So celiac disease is common. The prevalence is 1% globally. And what we do know is that the prevalence of celiac disease is increasing in areas that traditionally we didn't think had such a high prevalence, such as in places like India and China. We think that's probably due to increased westernization of diets. And interestingly, we know that about 2 out of 3 individuals are undiagnosed. And that means it's about 500,000 people in the UK have celiac disease, but are actually unaware of that diagnosis. Likewise, 1 in 4 individuals are actually misdiagnosed with IBS. And as Imran highlighted in the last talk, it's very important to check celiac serology in individuals presenting with IBS. And we know there can be significant delays in diagnosis, and that median delay can be up to 13 years in duration. So if you go back to our case, so our patient then tells us that she noticed symptoms while she's consuming gluten. Now, I'm sure that you have had patients come to yourselves in primary care and said that, I'm getting symptoms after having gluten. And the question is, how common is celiac disease in this context? So again, I want a bit of interaction from the audience here. So who thinks it's 3%? Yeah, so we've got a couple of hands. 5%? Okay, a few more. 10%? Okay. And 30%? So there's a bit of a spread there from the audience here. So it's 10%. So 1 in 10 individuals who say they have symptoms triggered by gluten actually have celiac disease. So it's important that we consider this and we don't just say, well, they've got, they're just saying that they've got symptoms triggered by gluten. So it's important that we do consider celiac serology testing in that circumstance. So our patient is a keen fan of tennis. They love Novak Djokovic, and they've read his book. And Novak Djokovic says, going gluten-free is the greatest thing to do. It's healthy, doesn't really matter. Even if you haven't got celiac disease, who cares? So she's already gone gluten-free. And again, I'm sure in primary care, you do see people like this that have gone gluten-free. And that poses a challenge for us. What do we actually do here? So probably traditionally, we've always said a gluten challenge that we should reintroduce gluten for 6 to 8 weeks. We say roughly about 10 grams of gluten, and that roughly equates to about 4 slices of bread. Now, we know that patients who've gone gluten-free, they've probably gone gluten-free because they've got symptoms, and they really are not keen on reintroducing gluten. And sometimes that can pose a challenge in primary care to ask a patient to reintroduce gluten for such a sustained period. And what I say to yourselves here is that, how about option 2? So there is data that suggests that actually a lower consumption of gluten for a shorter time period is another potential option. And we know that individuals who consume about 3 grams of gluten, so about a slice of bread a day for 2 weeks, we know the diagnostic rate in that situation is about 70%. So it's not 100%, but it definitely is an option for us to consider in those patients that are unwilling to reintroduce gluten for such a sustained time period. So luckily, we've got good persuasive skills, and we've actually convinced our patient to reintroduce gluten and have a gluten challenge for 6 to 8 weeks. And whilst they're on a gluten-containing diet, we then do celiac serology. So you'll see on this slide that I've mentioned that the TTG, or tissue transglutaminase level, is more than 128. So it's more than 10 times the upper limit of normal here. So here in Sheffield, our normal range is 0 to 7, but the TTG assays can vary depending on where you work. I've also mentioned here that the IgA levels are normal. And you might be thinking, well, why have I specifically mentioned that? And the reason why I say that is that about 2.5% of individuals with celiac disease will actually be IgA deficient. So you may actually get a false reassurance of a normal TTG if IgA levels are actually deficient. So it's important to think about that as well. And in that circumstance, we would do IgG TTG testing. But if we go back to this situation, so this patient's got a high TTG titer, what do we do now? Do we refer them for a gastroscopy, or do we refer them to a dietitian to commence a lifelong gluten-free diet? So again, this slide has been shown briefly this morning by Charlie, and these are guidelines that were published during the COVID pandemic as part of the National Gastro Guidelines from the British Society of Gastroenterology. And what I'd like you to do is focus mainly on the left-hand side of this slide. So you'll see in that red box, what I've highlighted is that individuals who have symptoms compatible with celiac disease with a high TTG titer, if they have endomycin antibodies that are also positive, we can make a diagnosis of celiac disease without the need for a gastroscopy and duodenal biopsy. But there are some caveats that we need to be aware of. And there are a few things to say here. If a patient has alarm symptoms, they still should be referred for a gastroscopy. Likewise, if they're above the age of 55, they should be referred because we're thinking of other concurrent pathology. And this model has good evidence for it, and we've published here in Sheffield and also globally showing that the sensitivity of using this approach for a high TTG titer is extremely high. And this is very similar to actually the pediatric guidelines for a no biopsy approach as well. But how about individuals who have a positive TTG, but it's not more than 10 times the upper limit of normal? What should we do then? Well, we should do what we've always done, and that is refer for a gastroscopy and have duodenal biopsy. So in secondary care, we would take 4 biopsies from the second part of the duodenum, as well as duodenal bulb biopsies to confirm a diagnosis of celiac disease. So our patient had high TTG titers with no red flag symptoms, and in view of that, they had a diagnosis of celiac disease made, and then they went on a lifelong gluten-free diet after seeing a specialist dietitian. Now, you might be thinking at this point, well, it's just celiac disease, isn't it? Does it actually matter? And what I'd like to draw your attention to is actually look at the impact that it has on a patient's quality of life. This slide shows you a nice graph that shows that individuals with celiac disease can have a worse quality of life than individuals with ulcerative colitis, and as bad as individuals with Crohn's disease. So it really has a significant impact on these patients, and it's really important that we think about the diagnosis and treating these patients. And what we want to do is to prevent long-term complications. And much like in conditions such as inflammatory bowel disease, we strive for mucosal healing. It is the same for celiac disease. What we know is that if you have healing in celiac disease, you're less likely to develop complications. And I think the thing to say also, though, is that the complicated celiac disease can occur, but it's still relatively rare. And there are conditions such as conditions called refractory celiac disease, where individuals have persisting ongoing villus atrophy despite being gluten-free for over a year, but that only comprises about less than 4% of the whole celiac cohort. But the key thing to say here is that we should be striving to put our patients on lifelong gluten-free diet to prevent these long-term complications. So I'm going to move on to the second and last case, which is going to be relatively brief. So we have a 72-year-old man who has been seen in primary care. He's had some blood tests done which show that he's got iron deficiency anemia. So then we refer him to secondary care under the 2-week wait pathway. But we ask him, do you have any symptoms at all? And he states that no, he's actually feeling okay. So he then gets seen in secondary care. He has a gastroscopy, and the gastroscopy is reported as normal, no biopsies needed. Colonoscopy is reported again, normal, no biopsies needed. And on the report it says, this patient has been started on oral iron. I'd be grateful if the GP could monitor hemoglobin indices and re-refer into our services as needed. Again, I'm sure that you've seen this from letters that you've received from gastroenterology. So my question here is that this patient didn't have duodenal biopsies and hasn't had celiac serology tested. And the primary concern was obviously cancer initially, but should we care about testing for celiac disease in the elderly population? Does it actually matter? So if you look at this slide on the right, this is a graph from data here in Sheffield, looking at the proportion of individuals that we see in the service here. And if you look at the purple line in this graph, you'll see that around 20% of individuals in our cohort are above the age of 65 with celiac disease. So it's not a small number of patients that we actually have. And what we do know is in the context of iron deficiency anemia, the prevalence of celiac disease is somewhere between 3 to 5%. We also know that elderly individuals with celiac disease may present with more subtle symptoms or fewer symptoms and maybe presenting with subclinical malabsorption, such as iron deficiency anemia. Now you might say, well, is there actually any point in testing? Well, what I would say is that if an individual does have celiac disease, and if they're elderly, there are risks of that. So you can get reduced bone mineral density, increased fracture risk, but there is actually no overall increase in mortality risk. But there are many reasons why we should consider it, because actually, if the serology is positive, that might prevent us from this patient having recurrent investigations. But again, I don't think there's a right or wrong here in terms of whether we should be starting this patient on a gluten-free diet or not, because we know following a gluten-free diet isn't easy. And when you're elderly, there's no real increase in mortality. So I think it's about empowering our patients and maybe doing the celiac serology and asking the patient what do they want and giving them that power and informed decision to do that. So our patient subsequently wishes to have investigations for celiac disease. He then has positive serology and subsequently undergoes a gastroscopy, which shows villus atrophy, keeping in with a diagnosis of celiac disease. Now, interestingly, our patient wanted to go gluten-free, and whilst initially he said he had no symptoms, actually on further questioning, he now attributes his slow activity and lethargy to old age, but actually, when he went gluten-free, he feels a lot better. And sometimes this is actually what can happen to our patients. So they think that because they're old, that's why they've got those symptoms. But, this is due to celiac disease in this scenario. So, what are my take-home points for you today from this talk? I think there are a few key things here. Firstly, it's important to make sure that a patient is on a gluten-containing diet whilst assessing for celiac disease. That can be challenging at times, but we do have potential options for patients that don't want to reintroduce for the full 6 to 8 weeks. Also, consider a no biopsy approach for a subset of individuals with celiac disease. So younger individuals, no red flag symptoms, high TTG titers, and positive endomysial antibodies. And finally, in the elderly population, we need to think about doing celiac serology. A lot of the times we can be focused on excluding cancer, but actually we should think about, should we be doing celiac serology and should we be empowering our patients to make that choice once that's done? Thanks so much for your time.